Earlier this month, the CDC released highly anticipated guidelines on opening schools amid the COVID-19 pandemic. But that guidance has been met with some criticism, both from people who claim it is too strict and others who say it's too loose. Now case numbers are dropping, but more children are dealing with long-term COVID symptoms. So what do school administrators need to consider? Let's bring in Children's Hospital of Philadelphia Policy Lab Director, Dr. David Rubin, for more on this. Dr. Rubin, thanks for joining us. We know you're busy. We appreciate your time. Curious to know what your take is on the CDC's specific case number and test positivity rate thresholds for reopening schools.
Look, I'm going to say right off the bat, I think the CDC kind of got it right on this one. I think the guidelines, people have to remember the CDC is speaking on behalf of all schools around the country, from our large urban school districts down to our smaller private schools. So, a lot of the critiques have recognized that individual schools need to make their own choices informed by the evidence. And I think what the CDC provides are relative lane markers for how to think about when to return to full in-school instruction or when to reopen for those who haven't reopened. And I think it's the principles that matter most in that document, that being recognizing that as case incidence continues to fall here in the spring, a big window of opportunity is now opening to return more kids to the classroom. And for those who would critique that those thresholds are really conservative, I think we're seeing the kind of declines now that many schools are going to see themselves push right past those thresholds, and we're going to get a lot more kids back to school.
And Dr. Rubin, the biggest point of contention that I've heard from school administrators is this recommendation of 6-foot distancing between children. Many say, one, it's just not doable. You can't bring all the kids back if you're going to try to force them to space out 6 feet because there's just not enough space in the schools. But also that other data has shown that 3 feet between children is sufficient. Do you think that 6 feet is totally necessary, particularly for the younger children?
Well, it depends on what's going on in community transmission rates. If there are more kids knocking at the door with COVID infection and you're really closely packing kids into a classroom, you potentially could get in trouble. And I think the CDC guidelines reflect that. Under a weekly case incidence of 50 cases per 100,000, they recommend full in-school instruction with 6 feet to, quote, the greatest extent possible. Now, to me, I interpret that to mean they recognize that you're going to have greater value in terms of preventing infections at 6 feet, but I think they've given enough flexibilities for schools to try to plan to use outdoor space as we go into spring, prioritize those opportunities to maximize 6-foot distancing, but they recognize that many schools are going to have to go underneath that barrier, but they're just saying, wait, you have a little patience here. We're seeing great declining case incidents right now, and your window of opportunity is opening. And for every school, they can look at that relative lane marker and decide, what their appetite for risk is as a school community, how well they've done in the fall. But I think the relative message there is we're getting there, and we recognize that we're going to have to break that 6-foot barrier.
And the other criticism that seems to be rising to the top is on ventilation. The fact that the CDC guidance barely mentions it, while some infectious disease specialists, that should have been number 2 behind masking. What do you think?
Well, our team actually agrees with what the CDC said on that. I think you have to recognize that throughout this pandemic, the basics of transmission and our knowledge of transmission has not changed. This is primarily a large droplet spread virus, which requires close proximity and sustained contact. It doesn't mean that under certain conditions and in the right environment, there might be some anecdotal cases of airborne transmission, but that is the exception rather than the rule. And if you acknowledge that, you recognize that ventilation, you make improvements to ventilation, but it is not a primary COVID prevention mechanism. Masking and distancing are your primary mechanisms in keeping sick kids out of school. So I applaud the CDC for recognizing that, because in some ways you can develop a paralysis thinking about ventilation as a key primary intervention when in fact it's actually a secondary intervention among the ones that work the best.
And then the CDC did a case study of a school in Georgia and found that teachers may play more of a role in spreading COVID than children do. So how much can that be helped by vaccinating teachers, as long as this question still exists of how much vaccines actually prevent the spread of the virus?
Well, we know that the older youth, the adolescents and adults are principally those who are most likely to acquire and spread the infection. We've seen that throughout this pandemic. It's not anything unique to teachers, but it recognizes that, obviously vaccination of teachers is certainly going to help, but we've spent a lot of time advising school districts to be mindful of how teachers and their staff move through the school during the day. Be careful of those break rooms when those masks come down and you have a cup of coffee with a friend, and then also recognize the value of testing, which was also recognized in the CDC guidelines as a way to provide sort of weekly assurance testing and focusing it on your staff to try to help prevent asymptomatic but contagious individuals from entering the school.
And then, Dr. Rubin, we're learning more about an uptick in multisystem inflammatory syndrome among children who had COVID or severe symptoms in children with acute COVID. How worried should parents be, and when do you think children will be able to be vaccinated?
Look, we can't entirely eliminate all risk, but still today we have the same evidence from the spring that the significant complications in children are extremely rare. The MIS-C, which we have seen increase a bit here late in winter, similar to last spring, occurred about 6 to 8 weeks after the big peaks in late December and January. But we're seeing now national declines in pediatric hospitalizations. They just lag behind the adult declines, but still, the number of hospitalized children remains very small compared to what we've seen among adults. And with regards to vaccinations, I think we do recognize that children, and particularly older youth, contribute themselves to community transmission and do have the risk of these rare complications. We're doing vaccine trials, I think, down to age 12 at this point. I would suspect by the early fall, once we have the data that comes in from those trials, we're likely to see our older children and adolescents line up for vaccinations.
All right. Dr. Rubin, we appreciate your time today. Thank you.
You're welcome. Have a good day.
You too.
Hi, everyone. George Stephanopoulos here. Thanks for checking out the ABC News YouTube channel. If you'd like to get more videos, show highlights, and watch live event coverage, click on the right over here to subscribe to our channel. And don't forget to download the ABC News app for breaking news alerts. Thanks for watching.